So I first want to welcome everyone to our webinar. I'm Laura Painter, and I'm Buckeye's Senior Director of Population Health Strategy. On behalf of the plan, we want to thank you all for joining us here today. We appreciate all the work and partnership you do to support our shared members. And in today's session, we're going to review some proposed behavioral health policy updates, discuss our approach, and outline next steps. And I want to share that we've carefully considered provider and advisory group feedback, and we're actively incorporating that both into our short-term and longer-term strategies. But right now, in the near term, we are advancing several initiatives to help promote greater consistency, reduce unnecessary variation, and help better align services with clinical best practices. So over the next year, we plan to continue strengthening our network management approach, including closer collaboration with our higher performing providers to help reduce an unnecessary administrative burden, and also explore expanding our risk-based alternative payment models to help better tie back to quality and outcomes. Today's discussion will be focused on our near-term initiatives, which include utilization management thresholds for several selected services where we identified significant service variation. So our goal is really to help ensure services are medically necessary and evidence-based. I will also share we do not have a firm go-live date yet, as we are actively working with Medicaid on policy revisions that were submitted earlier this month, and also based on feedback that we heard from our provider groups in early February. We are also continuing to work with Medicaid through the ARPA reconciliation. So once we become aware of the timelines and next steps, we will ensure that we provide that clear communication back to all of our providers once our implementation timelines are finalized. So again, thank you for being here. We look forward to the discussion. And now I'm going to turn it over to Brandy, Shar, and Megan, who are going to walk through the webinar.
Thanks, Laura. Just while we're waiting, and I see that there are still folks coming in, if you have any questions during the presentation, please use the Q&A feature. We're going to work to address the questions following the presentation. Today's presentation is being recorded. The recording and the materials will be shared after the webinar. If you experience any technical issues, just try logging out and logging back in. You can also use the chat feature to let us know that you're having trouble. All right. Oh, I'm sorry, back up one. Thank you so much. As Laura said, thank you so much for being here. My name is Brandy Hahn. I am the manager of behavioral health here at Buckeye Health Plan. We really appreciate you taking the time today to join us. We're going to walk through some of the upcoming behavioral health billing updates and talk about what they mean to you in your day-to-day work. So we'll spend our time on the things that we hear questions about most: utilization thresholds, what we're looking for around medical necessity and documentation, a few practical billing and submission tips, and where to go when you need help. The goal is to make this as clear, useful, and practical as possible. Next slide. So as I said, today's session focuses on behavioral health billing updates and how they impact providers operationally. The purpose of these policies is to establish utilization management thresholds for several behavioral health rehabilitative services like CPST, PSR, TBS, peer support, and IOP. These BH policy updates are designed to support consistent and fair review of services while aligning with Ohio Medicaid requirements. The updates do not reduce covered benefits, or place hard limits on care. Instead, they help us ensure that services are reviewed consistently and when in use is higher than typical, while still allowing providers to deliver additional services when they are medically necessary. Our goal is to support appropriate care, reduce confusion, and maintain continuity of services for our members. Next slide. So what this policy does is to set unit thresholds that signal when additional review may be needed to confirm medical necessity. That said, supporting documentation is only required when the services exceed the threshold. Further, it aligns with the Ohio Administrative Code in that there are requirements for transparent, evidence-based, non-restrictive practices. Our goal is consistency across providers and service types. Next slide. So what it does not do it's is equally as important. It does not reduce benefits, does not impose hard caps. It does not prohibit same-day services allowed by Ohio Medicaid or create blanket prior authorization requirements. Services may exceed thresholds when medically necessary. The goal, again, here is consistency and transparency, not restriction. Next slide. So this slide pulls together the key thresholds we want you to be aware of. And just as important, how we got here. We didn't land on these numbers in a vacuum. We looked closely at our own data over time, including how services have been used historically and how that shifted more recently. We also reviewed data from other markets and states, especially where we were seeing outlier patterns compared to typical utilization. That full picture helped inform where review points made the most sense. From a practical standpoint, TBS, PSR, IOP, and peer support each have defined unit thresholds that may trigger a review or PA when they're exceeded. For TBS, H2020 allows up to 25 units before prior authorization is required, and H2019 allows 8 units per day and 80 units per year. For PSR, H2017 and allows 8 units per day and 120 units per year. For IOP, H0015 allows 27 units per year, and peer support, H0038, allows up to 24 units per week and 26 units per year. You'll also see some combined unit thresholds when multiple services are billed on the same day, especially when they're billed alongside per diem services. I want to be really clear here, these do not prohibit billing. What they do is help us recognize when service intensity increases so we can pause, review the documentation, and confirm medical necessity. The goal throughout all of this is consistency and transparency. So making sure that reviews are based on data applied fairly across providers and still allow flexibility when members need more intensive support. Next slide. So next we'll cover medical necessity standards, what triggers reviews, and how to avoid denial through strong documentation. Next slide. So here's what happens if services go over a threshold. At this point, we're really just stepping back to do a medical necessity review. These reviews are based on Ohio Medicaid coverage rules, Buckeye's medical necessity criteria, and most importantly, how the services line up with the member's treatment plan. When we talk about medical necessity, we're talking about services that are needed to safely and effectively treat a behavioral health condition. It's not about convenience or volume, it's about whether that care makes sense for that member at that point in time. The strongest support you can give yourself in these situations is your documentation. That means clear, measurable goals, a solid reason for the level of or intensity of service, and some indication of progress, or why continued intensive support is still needed. Everything should tie back to an individualized treatment plan and be delivered by qualified staff. When documentation doesn't clearly support medical necessity, that's when providers can run into denials, audits, or requests for corrective action. And we want to avoid that just as much as you do. There's one takeaway here. If there's one takeaway here, it's this. Clear, complete documentation is the single most effective way to prevent denials. It tells the member's story, supports the care you're providing, and makes the review process much smoother for everyone. Next slide. So when a request goes over a threshold, the question is simple. Does the documentation clearly explain why this care makes sense for the member right now? So the reviewers will look for a clear link to the treatment plan, measurable goals in progress, or why more time is needed, a clear clinical reason for the level of service. Reviewers are not looking for perfect notes or long narratives, extra paper that doesn't add value, academic or one-size-fits-all language, reasons to deny care just because the needs are higher. So the bottom line is if the documentation tells the member's story and supports medical necessity, it does what it needs to do. Next slide. So think of documentation as the backbone of medical necessity. The key themes here are tie interventions to the treatment plan, demonstrate medical necessity, ensure no duplication of services, and meet provider qualification requirements. Next slide. Just a quick note on compliance. Like all health plans, Buckeye does retain audit rights, and that's part of making sure we're all aligned with Medicaid requirements. When documentation doesn't support the services billed, it can lead to things like claims denials, recoupments, or requests for corrective action. That's why, again, making sure that the documentation clearly matches the services that you're providing, and that is so important. It's really the best way to protect both your organization and the members that you serve. Next slide. So now we'll quickly review how coverage criteria applies across the key service categories. Next slide. Okay, so the key message here is the right service, right purpose, right intensity. Each service must align with its regulatory intent. So peer support is recovery focused and person centered. TBS and PSR are goal directed interventions that support functioning and skill development, while CPST supports stability, functioning, and coordination of care. Next slide. Peer support is grounded in the Ohio Revised Code as listed here. It's recovery focused, person centered, and connected to treatment plan goals. Providers must meet OMOS and OAC certification requirements, and is generally not delivered concurrently with high intensity services except when supporting admission or discharge. Next slide. TBS, again, the OAC is listed here. It's goal-directed, solution-focused. Activities include treatment planning, crisis prevention, social skills, daily functioning, restoration, and those services must be linked to documented treatment goals. Next slide. And you'll see here that the OAC is listed. And that's what PSR is based on. It addresses functional deficits or interpersonal barriers. So activities include daily functioning restoration, community integration, skill building, supporting self-management of symptoms that may interfere with community success. Pardon me. Next slide. CPST also references the OAC that's listed here. It supports members with diagnosed mental health disorder and functional impairment. Activities include ongoing assessment, skill development, crisis management, and ISP coordination. Pardon me. Pardon me. While the expected benefit is maintaining or improving stability, reducing symptoms, and preventing higher levels of care. Next. And lastly, IOP is based on the OAC listed here, and it aligns with ASAM Level 2. It requires ASAM multidimensional assessment. It's a structured clinical approach and is not concurrent with other SUD levels of care. Across all services, alignment to the treatment plan and medical necessity is absolutely critical. Next slide. And I will turn this over now to Megan Whalen here.
As long as I can find my mute button. Been having that challenge for the last six years or so. Good afternoon, everyone. My name is Megan Whalen. I am the Senior Manager for our Behavioral Health Utilization Management team with Centene supporting Buckeye's utilization management reviews. Next slide, please. I just want to spend some time today going over some of the things that my team is going to be looking for when we are receiving these utilization management requests. So a couple of keys to make sure that we have everything that we need. We really want to emphasize how important documentation is. As most of you know, as clinicians, if it's not documented, it doesn't happen. So we really want to make sure we have everything that we need to ensure medical necessity and compliance is appropriate for that member's current request. We also need to make sure that we have individualized treatment plans. So really making sure that what your treatment plan indicates is appropriate for the member is linked to personalized goals that the member has that you've addressed and come up with in partnership with our member. Also, we want to make sure that we're avoiding any duplication or anything like that, as Brandy did mention earlier, and make sure that our providers are meeting that provider qualification and clinical appropriateness standards. And some of those consequences, just a reminder, these can cause some claims denials, audits, and financial recoupments should there not be compliance with these needs. Next slide. I'm also going to be giving you some updates on billing and prior authorizations. So a little bit of an emphasis on some of the things that we've already talked on today, but a little bit more detail from the utilization management side. Next slide. This page just kind of indicates some quick tips to make sure that your submission is processed as timely and efficiently as possible for your teams. So making sure you've got accurate billing and timely submissions, really wanting to make sure that these help ensure the successful claims and avoid any delays or denials or potential denials. We also want to make sure that you are staying up to date with your submission thresholds. So you will be getting updates through our Buckeye group just to make sure that you have everything that you need. So if there are any submission threshold changes, you will be made aware. As far as best practices for submission, we want to make sure, again, that we're including all clinical documentation prior to submitting that authorization request so that when it does come through the portal, we have everything that we need and we're not, rushing around playing some phone tag, trying to get a hold of you and vice versa. We want to make sure everything is readily accessible for those medical necessity reviews. And then just some common errors that we do sometimes see. Incomplete treatment plans do come up. We want to make sure we have the most complete, most updated treatment plan. Sometimes we do see some missing medical necessity indicators, and we really want to make sure that you've provided everything for us to appropriately apply medical necessity criteria. And then the last common error would be submission deadlines being missed. So making sure that our providers are staying on top of those submission deadlines. Next slide. Really want to reemphasize that this policy is not requiring prior authorization for standard delivery of these services. This is really about establishing thresholds that may review prospectively or retrospectively with an opportunity to submit that documentation. And then one of the things that we do want to call out is that, as well as us following those timelines for any requests, we may require additional clinical information for review. Next slide. This slide is going to outline the process for prior authorizations. If you're not certain if a request requires a prior authorization, on the Buckeye website, you're going to find a prior authorization pre-screen tool. The link is in the you've got a hyperlink here, so you can access that when you get a copy of this information. But want to just really emphasize that if you're unsure, use this tool. It's the best way to find out. If it does require prior authorization, standard prior authorization requests need to be submitted at least 5 business days prior to that scheduled delivery of the service. So it's a prior authorization for the services to begin, not an authorization after services have been rendered. So really wanting to make sure that we're getting that with the most updated clinical information at least 5 business days before the scheduled date to start services. These requests can be submitted through our secure web portal or the Availity system and should include all necessary clinical information. Over on the bottom right-hand side, you're going to see some information as far as the portal submission process. You'll see 2 links to 2 different portals. You're going to have a Buckeye portal, which is secure, as well as our Availity system. You're welcome to use either of those. Here, you're going to be able to access the member's record select a new authorization option, and then complete the authorization form. Worst case scenario, if either of those portals are not working the way that you expect them to, you can also fax that authorization to the fax number listed below, and that will give you the same opportunity for that medical necessity review. Next slide. This is what our sample prior authorization request form looks like. This will be accessible through the Buckeye page so that you have access to it. This is a great way to make sure that you've got everything we need to apply medical necessity criteria. So for these services on this form, you're going to see some information that helps us build the authorization, your information, the providers rendering the services, NPI, TIN, all of that good information, member information, so we can correctly tie that authorization to the correct member, service requested, what codes are you requesting, what level of care does the member need, any clinical information to make sure that we have everything we need for medical necessity. Additionally, any functional concerns or medical necessity justification is helpful for us from your clinical perspective, as well as the clinical information to support the member's story. Treatment plan requirements, anything treatment plan related is going to also be included, as well as the provider attestation. So this is a sample of what you can use in order to submit for those prior auth requests. Next slide. And I'm going to pass it over to Ms. Shar, who's going to take you away on a little bit more information.
Thank you, Megan. I'm Charlene Brubaker, and I'm a provider network manager here at the Health Plan. And I just want to share with you some resources that are available to you. And first being that appeals and denial process information that you will receive. Next slide, please. I'm sorry, I forgot to say that. The next slide actually does talk a little bit about reviewing that denial notice. If you receive an adverse determination in that denial notice and letter of notification, you will have an outline of how to submit a peer-to-peer request or how to submit your appeal request. So please follow all of those instructions for your next steps that are included in the letter that you'll receive. And here's just a sample of that letter on the right-hand side. Next slide, please. And I will get into some additional resources that are available for our providers on our website. If you'll go to the next slide, please. I know that Megan mentioned to you the provider portal. We have two portal options as it stands today. The first one being our Buckeye portal that you can submit those prior authorization requests through. We also have on the next slide the Availity portal information. And these two slides actually will give you some of that contact information should you experience any difficulty in order to get that authorization submitted. Next slide, please. Then if you do have any other questions or come across anything that you have any difficulty with, your first point of contact should always be provider services. Provider services should be able to assist you in getting anything that you need, but should you not be able to get what you need through provider services, you can certainly contact your provider engagement account manager. Next slide, please. That provider engagement account manager, you can identify who that is by going to the link here. You have a hyperlink once you receive this slide deck, and you'll go to that and you can type in your zip code, and it will then share with you who your provider engagement account manager is and how to contact them. And they will be more happy to assist getting you to the right area or working to be that liaison between the provider and the health plan. If you could go to the next slide, please. One of the other important things that we share with providers that we always point them to that provider homepage on our website where they can obtain so many resources available to them. There will be a specific page created for this BH process for these policies, that you'll be able to find this webinar and frequently asked questions and additional information like that prior auth form that Megan shared. Everything will be available to you on the website, but we point you to that provider homepage because this is where you'll be able to access important information. You can go to that information by clicking on any of the links on the left-hand side, and or you may have seen when we announced that this was going to go live in January and then also on December 23rd that we put it on pause until we had an opportunity to share this information with you through that provider bulletin and through those updates on that homepage. Could you go to the next slide, please? And some additional resources that are available on that website. I just want to make it known that you can access clinical payment system errors on that information on that provider resources section. You can also access our provider portal. You can go to find a provider. You can also access multiple forms and additional information. Next slide, please. So those key highlights, I would say, please always access your provider manual for the most up-to-date processes and pay attention to that provider bulletin that comes out monthly. There's also that additional training and education available to you. And as Megan mentioned, that prior auth check tool is always a provider's best friend. If you could go to the next slide, please. That provider network operations slide, we put this in here because we know a lot of providers have changes to their roster frequently where they have providers leaving the practice, joining the practice, updating specialties for their providers. If you're in 8495, we certainly get most of that information from that PNM through Ohio Department of Medicaid. But if you're experiencing any claim issues or things, you might find that certain specialties aren't coming over through that. So we ask that you reach out to Ohio Contracting at Centene to have any of that roster update completed. Also, we do have other lines of business that you might be participating in, and it does require that provider data form or roster to be shared with us. And this is how you would update that roster information. Next slide, please. I want to mention the provider communication sign up just because that's where most of our notification goes out to providers when we notify of any material changes. Plus, anything that might be upcoming in the next few months, we would go out in that provider bulletin at the end of the month, every month. So please go in there and sign up if you're not receiving that today. Next slide, please. I will turn it over to Brandy for any additional contact information, and I believe she's going to go through some of our frequently asked questions. Brandy?
Thanks, Char. So next slide. I think we've shared this before, but we do have provider services listed here and how to contact. Please make sure that you're allowing 3 to 5 business days for any sort of reply. Next slide. What we are going to do is make sure that you're using the provider services or secure messaging via the portal for any questions that you have around these changes and updates. As we wrap this up, we just want to make sure that we do look at some of the frequently asked questions that we have already seen when we initially started this launch a few months ago. So next slide. So again, what services are covered in this frequently asked question? It's PSR, TBS, peer support, CPS, TIOP, PHP. All of these services have to meet the OAC requirements and Buckeye policy. Next slide. What does medically necessary mean for these services? Again, we dove into medical necessity, but the member needs to have a documented BH diagnosis with functional or clinical needs. Services are tied to the goals, and there's that individual treatment plan. Interventions are clinically appropriate and not duplicative. And the services are provided by qualified staff and properly documented. If these elements are missing, services could be denied or recouped. Next slide. So the key service definitions, high level. We did talk through these previously on a side, but it does go over the PSR, TBS, peer support services, and IOP again. Next slide. Can rehabilitative services be billed on the same day as IOP, PHP, or TBS per diem? Yes, but limits will apply. So again, you will see here what we went through earlier in this webinar. Next slide. Okay, so what are the daily limits on non-IOP PHP days? When no IOP, PHP, or TBS per diem is billed, a maximum of 16 total units per day. It applies to all rehabilitative services combined and applies even if multiple provider organizations are involved. So exceeding this limit without authorizations can result in denial or recoupment. Next slide. Another multiple rehabilitative services question, can they be provided on the same day? Yes, if the following are met. Each service has a different purpose. Services do not overlap in time. Each service is documented separately. Each service supports a different treatment plan goal. And CPST for care coordination and PSR for skill development may both be allowed. Next slide. We talked about the documentation that's required, but for every billed service, providers must maintain separate progress notes, start and stop times, clear clinical justification, linkage to individualized treatment plan, evidence services are non-duplicative. Again, poor or missing documentation could result in claim denial or recoupment. Next slide. Are there exceptions to unit limits? Yes, but only with explicit authorization from So medical necessity must be clearly documented. Approval must be received before billing above limits, and units billed without approval will not be reimbursed. Next slide. Does it matter if different providers deliver the services? No. The units apply per member per day. Different limits apply even when services are delivered by different agencies, related organizations, or multiple rendering providers. Next slide. And again, here's the contact information for provider services. And then you can contact the provider engagement administrator that Shar shared earlier in the slide presentation. There is a website and you can find that PEA who is assigned to work with your agency. Next slide. Okay, we will be compiling the questions that were in the Q&A today and answer them following the webinar today. So that will be something that will be out within the next few days. And again, just to wrap this up, these thresholds are really just a signal for when we may need to take a closer look. They are not, they are not caps on care. What matters most is telling the member story clearly in the record with goals that you can measure and track over time. And if you ever get stuck or have questions, you have options. And we're here to help through the provider portal, Availity, provider services, and our provider engagement team. So as these policies go live, we will stay closely connected with you. We'll support the transition. We'll definitely talk through real world scenarios and offer in services whenever they're helpful or requested. I'd like to thank you for your time today. And I hope that you have a great afternoon.